Hello, welcome to Expert Insights on Vitiligo. How do emerging treatment options have the potential to transform patient outcome? My name is David Rosmarin, Chair of Dermatology at Indiana University School of Medicine in Indianapolis, Indiana. You can see my disclosures here. Joining me is Dr. Raj Chovatiya.
Hey folks, Raj Chovatiya coming to you from Chicago, Northwestern University. My disclosures are here, and a really pleasure to join you, David, on what's going to hopefully be a really fun hour.
You can see here our learning objectives, and we're really going to be focusing on the epidemiology, the pathogenesis, the comorbidities, the current treatment options and emerging treatment options within vitiligo. And hopefully it'll be an exciting discussion between myself and Dr. Chovatiya.
So this is our agenda for the evening. As you heard David mention, we're going to really taking a soup to nuts approach for vitiligo. So we're going to talk about the burden of disease, how common it is, what you think about in terms of other conditions somebody might have, what's going on below the skin, below the surface in terms of the immune system and the skin cells, and how do we leverage those findings to really think about treatment, both historically what we've done and then what's emerging in the last couple of years as far as ways that we can treat vitiligo. Finally, we'll take a quick touch on some practical care coordination, and then we'll bring it all together. So before we get rolling, we have our first discussion question. So get those fingers ready. I'm going to read through this, and please respond to what actually is kind of a tricky question, and hopefully David knows it, but let's see here. So what is the prevalence of vitiligo in the United States? Is it A, less than 1 million? B, 2 to 3 million? Is it C, 5 to 8 million? Or is it D, I don't know? All right, so we'll give you guys a little bit of time to respond. I know there's going to be sort of answers rolling in. What do you think, David? Tricky question?
It is. It is a tricky question because as we'll soon see, we don't know exactly the right number, but we do have our estimates to answer that. So I'll give you what we think the right answer is.
Yeah, it's interesting with prevalence. There's been a lot of really cool studies recently that have tried to take different types of sampling design to understand what might be going on. And there was a really nice one that was done that actually involves sending in sort of photos in the US and sort of trying to take a look to see what might be the undiagnosed burden. So like you mentioned, it's always kind of tricky to kind of know what you don't know. But let's take a look and see what's going on in terms of the live audience response. It looks like, taking a look at the answers, 2 to 3 million is winning out. There's a fair number of people saying that they don't know as well. So I think that there's definitely some good potential learnings to be had here. Should we keep things going forward, David?
Perfect. So let's go over the epidemiology and the answer. And we believe that vitiligo affects about 1% of the population. And that's true in the United States as well as worldwide. So that's where we get our estimates of 2 to 3 million people affected within the United States. And we know that vitiligo can affect all races, ethnicities. It can affect people at any age. However, it often affects a younger population, so much so that about half of the people will develop vitiligo by the age of 20 and up to 80% by the age of 30. Now, in terms of the estimates of how many people who have vitiligo, one of the challenges is there may be people out there that don't know that they have vitiligo. Maybe they're fair-skinned and they don't realize that they have lighter spots that are vitiligo. And that's where this estimates that maybe up to 40% of adults may be undiagnosed. And that's part of the reason why it's so challenging to know how many people in the US really have this condition, but we believe it's around 2 to 3 million. In terms of how do we categorize vitiligo, there have been different ways in the past, but we predominantly use non-segmental vitiligo or segmental vitiligo as our two main categories. And when we say vitiligo in general, you're really referring to the non-segmental type. It's just strange to refer to a negative as what's the predominant type of vitiligo. The segmental type is predominantly localized to one area. Some people want segment relate. Most often on the face, the second most common area would be the trunk. Commonly occurs in a more pediatric population, and there's rapid expansion of vitiligo over 6 months to 2 years, upon which time it stops and stabilizes. There's also more white hairs or leukotrichia, which is associated with the poorer prognosis. Now, in contrast, the non-segmental vitiligo is more often symmetric. It likes areas that are naturally hyperpigmented, such as the face, particularly around the mouth and eyes, elbows, axilla, genital region, dorsal hands and feet. And it can be active or stable, and that can switch at any point in life. And for the purposes of this talk, we're really going to focus on that more common type of non-segmental vitiligo. I do want to note, though, that patients can have a mix of type of both non-segmental and segmental as well. But for the most part, when we say vitiligo, we're really talking about that non-segmental type. And a practical tip is you always want to comment if the patient is non-segmental vitiligo in your medical note. Why? Because insurances may use that as a reason to deny treatment. So please document if it's non-segmental vitiligo. That can help patients get the therapy that they deserve. So in terms of vitiligo, the first thing that I always try to differentiate after figuring out is it non-segmental or segmental is the disease active or is it stable? And the number one concern for our patients is whether the disease is spreading or not. They have more anxiety over whether they'll get new spots or not than any other feature with the vitiligo. So there are 4 main types that are associated with the vitiligo being active or spreading. One is if they have trichrome vitiligo, which you can see in the upper left, where you see the normal skin, the depigmented skin, and then a third color in between. Second is if they have confetti vitiligo, as you see in the upper right, which is 1 to 2 millimeter depigmented macules. Third is if you see the Kevner phenomenon, where maybe a scratch induces vitiligo. And then last, which is very rare, very uncommon, is inflammatory vitiligo, where there is a erythematous ring around the vitiligo. It's not red throughout, but there's a annular erythema to the vitiligo, and it's a little bit more associated with pruritus as well, because typically vitiligo is asymptomatic. Raj?
Yeah, let's touch a little bit on the burden. Now that we have an idea about what we might be looking for and how potentially common or undiagnosed vitiligo actually is. I mean, there's an obvious component to this discussion that vitiligo is visibly something that you can notice. It's a highly visible diagnosis. And just given that what you see is so closely intertwined with your own personal identity, you can imagine what a major burden this probably creates on individuals experiencing vitiligo. And based on a number of different studies, you can document in terms of various scoring systems, reduced quality of life, changes in self-esteem, isolation, interpersonal relationships getting disrupted. We know that stigma, particularly in certain countries where vitiligo can be associated with really questioning one's marital status or eligibility for marriage itself, potentially a reason or grounds for divorce, or an idea that somebody might be infectious and other, therefore they're kept away from individuals, as we've noticed throughout years of history. There's an increased risk for comorbidities that we oftentimes don't necessarily think about all the time. In the case of vitiligo, it's not really just an asymptomatic skin rash and nothing on its own. Mental health disorders, including depression, is a really big one, especially in sort of many of our adolescents and young adults, where we know that there's a higher prevalence of some of these mental health conditions. And we know that there's a strong overlap on vitiligo and psychosocial burden. And of course, those that have darker toned skin may be profoundly affected because, as you heard, with those individuals that have lighter toned skin, it may be a little more subtle to actually see the signs of vitiligo, but it's much more apparent in somebody that has much more dense pigment concentration. So let's talk a little bit about those comorbidities then that I just mentioned. Vitiligo is really not just a skin disease, right? So vitiligo can be associated with a variety of different autoimmune, connective tissue diseases, systemic and dermatologic conditions. We oftentimes think about certain autoimmune conditions, most commonly with vitiligo, Thyroid-related disease is one of them, but there are others in general. If you have large enough sample sizes, you can usually find a statistically significant association with a whole host of conditions cross-sectionally based on some of these large database analyses. In general, if I had sort of a diagram of the human body up here, you would see that there's really potential association with diseases involving all sorts of body compartments and body systems. Additionally, it's worth noting that when it comes to thinking about the skin in particular, we oftentimes, as dermatologists, are thinking about skin cancers and melanoma. We know melanoma is, of course, related to the actual presence of melanocytes and melanin. There's actually a threefold less risk for melanoma versus the general population. This has everything to do with sort of the actual milieu of skin cells that are left in somebody that has vitiligo. Back to you, David.
So now we're going to talk a little bit about the pathophysiology of vitiligo, which has been better elucidated more recently. But before we get to that, we have our next ARS question. Which of the following is one of the key cytokines that is thought to drive the pathophysiology of vitiligo? Is it A, interleukin 4, B, interleukin 31, C, TNF alpha, D, interferon gamma, or E, I don't know. Let's wait till the next slide to find out.
Looks like they did pretty good, David.
So currently, most people are saying interferon gamma, and that is correct. That is the right answer. It's really interferon gamma that is driving the pathophysiology. So just to review some of the results of these cytokines is that we know that when you have a disease like psoriasis, that's Th17 driven. And cytokines like interleukin 23, interleukin 17, and TNF are really key cytokines in the pathophysiology of psoriasis. In contrast, we have atopic dermatitis, which is primarily a Th2 driven disease. And some key cytokines are interleukin 4, 13, interleukin 5 and 31 are also involved. Interleukin 31, sometimes we refer to as the itch cytokine. So that's where interleukin 31 comes in. And in contrast, vitiligo is fundamentally a Th1 disease. It's interferon gamma driven. And there's some kind of stress that can be triggering to the pathophysiology, but ultimately it's interferon gamma that's signaling to our T cells through the JAK-STAT pathway, particularly JAK1 and JAK2. And it's those T cells that are then going back and destroying the melanocytes. Now, some other signaling molecules that are involved can be these signaling chemokines like CXCL9, CXCL10, which are involved with recruiting those CD8 positive cytotoxic T cells to destroy the melanocytes. But fundamentally, that's the problem. And I also want to comment that even after we treat vitiligo, sometimes the disease comes back. And why is that? Well, we have these resident memory T cells that are still remain, which are dependent on interleukin 15. So based on these cytokines and these signaling molecules that are involved, well, that's where we're going to try to target to get our patients better. And through the work of our scientists, really to elucidate that it's the Th1 pathway, that's really the key at helping develop new emerging therapies that are going to be effective for our patients. Back to you, Dr. Chovatiya.
Thanks, David. So that kind of takes us to what is going to be the central core aspect of our presentation tonight. And we're going to try to walk everybody tuning in through a pretty typical case on something that Dr. Rosmarin or myself might see in clinic on any given day, and hopefully use this to elucidate some of the more practical principles that we think about when it comes to vitiligo. So here's our case. A 30-year-old female, hypothetical patient, of course. And we're going to talk a little bit about sort of her history, some of our assessments, physical exam, and treatment that we end up thinking about for her. So let's get started. We have a 30-year-old female. She presented to the clinic with loss of pigmentation on the forehead, the cheek, the eyelid, hand, left arm, left foot, and axilla. Already Great history because you documented all the body parts where something was going on. You'd be surprised how often we just talk about depigmentation. So another key point, really keep track of what's going on in your medical documentation. First notice these depigmentation happening about 18 months prior to the clinic visit. So it's been about a year and a half. Started on the dorsal hands and it's been progressing to other new areas of involvement appearing over time. There's no itching, burning, or other symptoms in the area of concern. And we talked a little bit about when you might expect or not expect symptoms. All the areas were distressing to her, most notably in the area around the eyes. This made her feel very self-conscious, embarrassed, and really some difficulties in socializing. In her own words, she said, I knew it was going to be a problem when I just finished lunch with a friend and she said, you have something on the side of your mouth. Otherwise, she's been feeling well, but worried that the depigmentation would continue to spread. Another point I'll make about this medical history, very, very thorough, and we can all sort of learn from the challenge of documenting this much, particularly when thinking about some of the aspects of burden that this disease causes in patients. So let's think about some of the other history elements. There's no known allergies. She worked as a social paralegal, mostly office work, occasional travel, never married, and no offspring. So she has one sister with systemic lupus erythematosus. Her father had thyroid disease, and she denies any other history of atopy or autoimmune disease or family history of similar skin changes. She enjoys the occasional alcoholic beverage. She's a non-smoker with no exposure to secondhand smoke. She regularly eats junk food, woman after my own heart, and frequently visits tanning salons. Her medications are pretty simple, basically OC and a multivitamin. She's tried triamcinolone 0.1% ointment. So this might be a common story for someone coming to see us at the recommendation of her primary care physician and did not notice any improvement. She could not recall any significant changes in medications or personal care products in the months preceding the onset of skin changes. So I'll say, just highlighting a couple elements of what we just talked about, this idea of duration, treatment, burden, some of the other stuff in your life. This is kind of the classic stuff that you really want to do a good job of documenting and capturing for anybody that might be presenting with depigmentation as a potential complaint. Now, this brings us to our next question. David?
So, having heard the case, which of the following tools would easily help assist you in diagnosing the vitiligo? Is it A, a Woods lamp? B, CBC with differential? C, an ANA or anti-nuclear antibody test? D, a skin biopsy? Or E, I don't know.
This one's kind of tricky, right? Because you might potentially be thinking about some of these for a lot of dermatology patients, or even if you're suspecting something kind of in the autoimmune spectrum like vitiligo, right?
Yeah, so you hear that family history of lupus, and you might say, well, I may want to check in an ANA given the fact that the lupus is running in the family, and maybe my suspicion would be a little bit higher. Well, is there concomitant connective tissue disease? This person is going to be at higher risk. But would that help with the diagnosis of vitiligo? And typically not. So here we see some people saying Woods lamp, and also some saying really skin biopsy. And the right answer here is meant to be Woods lamp. Then the Woods lamp is a UV light that helps enhance the contrast between the depigmented and normal skin. So that if you see that contrast enhancement on Woods lamp, it helps tell you that there's depigmentation and this is vitiligo. As opposed to if it were just hypopigmented, you wouldn't see that contrast enhancement. Also, it's especially important to use a Woods lamp on somebody who may be skin type 1 or 2, where it can be really hard to see the extent of the vitiligo. Some patients don't realize how extensive it is, and may also often get emotional if they start to see that it's more than they thought it was when they first came in. Now, in terms of a skin biopsy, that can be helpful, but really in very rare occasions. If you take a skin biopsy of vitiligo, you see an absence of melanocytes. However, usually we don't need to do that for diagnosis, and Woods lamp and a clinical picture is enough for the diagnosis alone. But There may be certain
I'll-
circumstances when the skin biopsy.
Yeah, I'll throw it out there and say that if there's a differential diagnosis of some sort, then you're thinking about hypopigmentation or even depigmentation associated with potentially some other inflammatory cause. It's not unreasonable, but for sort of most rank and file vitiligo cases, clinical diagnosis is typically sufficient.
Yeah. So when I see a patient who has vitiligo, I am asking myself several things. Well, one is, does this fit the typical clinical picture, right, which is often symmetric? Is it completely depigmented, or is it early vitiligo that's evolving to be completely depigmented? Does it have those typical locations? Also, I'm asking myself, does the person have a family history of vitiligo? So a patient is about six-fold more likely to have vitiligo if they have a first-degree relative that also has the disease. And one of the questions I often get is, oh, doc, will I have kids that have vitiligo? And the chances are probably won't happen. It's about a 4% risk for somebody who has vitiligo to have a kid that has vitiligo. And so I think that's important, that people shouldn't be fearful of that, but that is higher than the baseline population. Also, I may do some review of systems to see if there's a risk for any comorbidity. The most common comorbidity by far is autoimmune thyroid disease. So either overactive or underactive Hashimoto's or Graves'. That's by far the number one comorbidity. It's seen in up to 25% of patients who have vitiligo. Now, whether we do a TSH screening or autoantibodies, that's somewhat controversial. Some people will do it, some people don't. Do you check a TSH, Dr. Chovatiya?
Yeah, I mean, I think that I historically used to always do it in every patient, but then I started at least being a little more limited, thinking about medical cost and burden and making sure, am I looking at an age group where this is relevant and other historical concerns I might have where this is relevant. So I still think that there's a lot of value in the test, but at least pausing before ordering a lab can be helpful in my case.
Yeah, I commonly check a TSH at the first visit that I have a patient with newly diagnosed vitiligo, or if they've had it done recently, I won't recheck it. But just because it's very common in this patient population. The other autoimmune conditions are much less common in general, such as pernicious anemia, such as type 1 diabetes. And therefore, I wouldn't do a screening test for those autoimmune conditions, but just what's appropriate based on review of systems. In terms of what else we're doing, it's really important to find out how extensive the disease is for a patient and try to get a rough body surface area. And then also determine, is the disease active or is it stable? That's really critical and helps determine next steps. So I'm looking for those 4 signs of activity and asking the patient, has this been spreading? But sometimes patients don't know. And again, just to review those 4 signs: trichrome vitiligo, confetti lesions, Kedner phenomenon, or inflammatory vitiligo. So if I see one of those 4, I'm concerned that this is active, and I'm going to want to address it, and we'll discuss how to do that in the next session. Now, one of the key aspects to vitiligo is, right, the fact that it's depigmented, not really hypopigmented. So one of the things that people will come in thinking that they have vitiligo is if they have pityriasis alba. So if you see a kid with a history of eczema or atopic dermatitis with hypopigmentation bilaterally on the cheeks, they can be reassured that this is pityriasis alba. Sometimes patients are concerned because of tinea versicolor, which can also be hypopigmented, but really not depigmented. And that's, again, where the Woods lamp can be extremely helpful. And I think those are probably the 2 most common conditions that patients come in with, thinking that they may have vitiligo. They may have Googled it and say, oh, this is what I have. But always helpful to keep in mind the differential. Okay.
So let's kind of continue with our case here. Okay, so let's touch on the physical exam first. The assessment tells us that there is depigmented macules and patches on the dorsal hands, left forearm, left dorsal foot, the axilla, the forehead, both eyelids, periorbital region, and the lateral cheeks. There's no erythema, within the depigmented areas, which is important based on what we just talked about in terms of inflammatory lesions. Skin temperature in the affected areas felt normal. The total BSA was approximately around 2% or so, which we know is kind of a gestalt measure that's used in day-to-day clinical practice, even though it's tricky to really sort of calculate something sheerly by BSA with vitiligo. The patient couldn't identify any other exacerbating or alleviating factors, and other lab tests and skin biopsy were not particularly indicated in this patient. So just one point that we'll bring up, and again, this is sort of taking a look at the vitiligo lesions, and we just talked a little bit about the Woods lamp in terms of accentuation of those areas of pigment loss, which is kind of what you're seeing in this photograph over here for just a little bit of context.
Yeah. So I think that picture that Dr. Chovatiya showed really nicely highlights what you can see on Woods lamp, really highlighting that depigmentation, that enhancement within the picture. Now, I always like to put down a rough body surface area, and we commonly think of body surface area using hand units, particularly for the body, where the palm, and it's the patient's palm, is about 0.5% of the patient's surface area, and the whole hand for the patient will be about 1% of the body. Now, in clinical trials, we may use the VASI, the Vitiligo Area Scoring Index, as a tool, but it's really not done within the clinic because it's more cumbersome to do within a busy schedule. So what the VASI score is intended to do is measure the amount of depigmentation, and the key is depigmentation. If a patient is hypopigmented, that is, or hyperpigmented, that's not counted within the tool. It's only the amount of depigmentation, and it's the surface area times the degree of depigmentation. So if within a patch of vitiligo, there's some follicular repigmentation, well, then that gets subtracted out, or really it's multiplied by some multiplier. And that's what the VASI score is. The VASI has also been modified for the face, which we call the F-VASI, as opposed to the total body, which would be the T-VASI. And because the face occupies up to 3.5% of the total body surface area, that's the maximum score for the F-VASI, would be 3.5. Now, you've heard of the PASI score and EASI score, which are analogous. Those scales go from 0 to 72. Whereas the total VASI goes from 0 to 100 because it's a body surface area score. So if you have total complete depigmentation, well, that would be a VASI of 100. And similarly, if you have half of your face that's depigmented, well, then that would be an F-VASI score of 1.75.
So let's just touch on the ending part here of our assessment of the patient. We've asked about signs, symptoms, medical history, done an exam. In terms of some of the comorbidities here, TSH as well as TPO and TG antibodies are tested and found to be within normal limits. So it doesn't seem like thyroid disease is of major concern to our patient at the moment.
So how would we treat a patient like this in vitiligo in general? Well, the first thing that I mentioned I try to assess is the vitiligo spreading or is it stable? Very important to determine that. Now, if it's spreading, my first goal is to stabilize the disease. And the primary way I would do that is with oral corticosteroids. And there are studies showing that dexamethasone, about 2.5 milligrams, given on 2 consecutive days for about 12 weeks, stabilizes disease in about 90% of patients with really minimal side effects. So I think that's one of my main strategies. Now, if that were not to work, you could always try doing that for longer or increasing the dose up to 5 milligrams of dexamethasone on 2 consecutive days for another 12 weeks or so. Now, another option to help stabilize the disease and can also help start the repigmentation process would be a phototherapy, particularly with narrow bands, UVB. So those are the 2 main options we have for helping stabilize our patients in terms of the vitiligo. Now, once we accomplish that, the next question is, well, how do we help treat these patients really effectively to help with the repigmentation process? And for that, we are basically dividing patients into those who have very localized disease, where topical makes sense, so maybe 10% or less of the body surface area, or patients who have more extensive or generalized involvement. For patients who have more localized disease, we're thinking about topical treatments. And that includes really three main options. One, corticosteroids, calcineurin inhibitors, particularly tacrolimus ointment, and then three, ruxolitinib cream, which is currently the only FDA-approved treatment for repigmenting non-segmental vitiligo. Now, if patients have the disease more moderate or severely, we may also discuss with them more systemic options, such as narrowband UVB phototherapy. And some key there is that it's not the frequency of treatment, but the total number of treatments that patients get that's ultimately responsible for their final result. Also, some people may use oral JAK inhibitors, which are off-label. In terms of using PUVA, that's really not used as much anymore because our studies show that narrowband UVB is more effective than PUVA. So we really discourage that use. Other options that we also look to more as third and fourth line treatments can be basically melanocyte transfer. So if a patient has stable disease and we're sure it's stable and they don't have the Kebner phenomenon, and they have a small area, they may be a candidate to take melanocytes from normal skin and transfer them over to the depigmented areas, and patients can have great results that way. And then lastly, for certain candidates that may want complete depigmentation, we have certain options such as monobenzone. However, there are very few people who really fit as good candidates for that option, but the ones who do it can have quite high patient satisfaction. Now, one thing that we're also in the process of studying is concomitant treatment. So it may be that topical treatments or systemic medicines that help suppress the immune system combined with phototherapy may even be better than either alone. And so that's currently under investigation, and we think that strategy might work. So utilizing our topical corticosteroids, calcineurin inhibitors, or JAK inhibitors with narrowband UVB phototherapy or excimer laser is often our go-to option for our patients. If patients can't do the phototherapy due to inconvenience, and perhaps just starting out with one of our topicals. Thank you, Dr. Chovatiya.
So let's kind of jump into some detail about what Dr. Rosmarin just told us about. And so in general, treatment is centered around a few simple principles. We're trying to essentially stabilize disease, so stop depigmentation. We're then trying to drive repigmentation and get us to a point where things can stay stable. And so as you can imagine, this is a multi-step process, so this takes time. We're so used to thinking about a world in dermatology that's on the order of weeks, even a few months, but this whole process is a multi-month, if not longer process. So in terms of really trying to get rid of that oxidative stress, correct an aberrant immune response, and create an environment where melanocytes can regrow and proliferate, you're really trying to do a lot of things with vitiligo therapy. So there's a lot of different things that can impact therapeutic outcomes. Some sites of the body tend to repigment better than others. A lot of this has to do with follicular density, knowing that that is the reserve around the follicle region where many of these melanocytic progenitors might reside. So something like the face does a way better job than, let's say, somewhere around the hands where there really isn't sort of that much density going on. Additionally, there's other factors to touch on in terms of sort of how long someone may have had disease, how old they are, sort of duration of therapy, whether or not you're seeing sort of total whiteness of the hairs or lesional white hairs, leukotrichia. Typically, that's a sign that there really isn't any pigment left in that reserve, meaning that you're not really going to be able to get functional melanocytes migrating out and repopulating an area. Additionally, confetti lesions and trichrome lesions as signs of really rapidly progressing disease as well are things to look out for. Now, we talked about some of those topicals, and let me kind of review what we used to have before Dr. Rosmarin jumps into sort of some of the newer stuff. In general, topicals are first-line therapy for limited disease. Maximal repigmentation of face and neck is kind of what's clinically been observed. Topical corticosteroids, of course, are readily available fairly cheap and found in a variety of different formulations. They seem to work when you combine them with narrowband UVB as opposed to by themselves, where they're not as effective relatively. Usually your maximal results are happening somewhere in the mid to high potency preparations. You are going to be limited by potency for particularly sensitive body areas, just like the face. Chronic topical corticosteroids can drive atrophy, acne, telangiectasia, loss of subcutaneous fat, even sort of other pigmentary problems on pigmented skin as well. So something that is just a major drawback for chronic topical corticosteroid therapy. We know that with calcineurin inhibitors, they also have efficacy that's been documented over time, also particularly alongside light-based therapies like narrowband UVB or eczema. You don't have the steroid-related complications, which is nice, but there can be other cutaneous adverse events like sort of stinging or burning that can go along with calcineurin inhibitors that can limit their use in some individuals. Additionally, long-term use in maintenance therapy, that's kind of a place where they shine. And sort of some individuals will try this initial approach with a stronger topical steroid, then pull back from maintenance with topical calcineurin inhibitor. Phototherapy is another really important modality. I know Dr. Rosmarin uses it quite a bit. I do as well across inflammatory diseases, but particularly in vitiligo. We know that narrowband UVB especially is the one that balances efficacy with safety in terms of sort of relatively low to not really any sort of definite documented skin cancer risk compared to PUVA, which was a UVA-based therapy that involved the use of a swirlin as well, which was historically used quite a bit, but does have certain risks and limitations on how long you can use it. So you can see here in this meta-analysis of a number of studies, there was actually a pretty moderate response in about 37% of individuals at sort of 6 months and 57% at 12 months, and a marked response sort of in sort of relatively good numbers as well, but particularly with the longer treatment. And you can see that this extended sort of not only across the face and neck region, but other body areas. As I mentioned, the hands and feet in general just are oftentimes very, very tricky when we're thinking about driving repigmentation. Autologous grafting is another one that's worth mentioning, noting that this isn't going to be a technique found everywhere. It's usually going to be specialized areas. And so stable focal and segmental vitiligo can be helpful here when you have areas that are not responsive to medical therapies. You could have suction blister grafts, melanocyte transplants, punch grafts, sheet grafts, essentially trying to take healthy melanocytes or particularly melanocytic progenitors into areas where they don't exist and allow their proliferation. And so that's kind of the grafting aspect of it. And you can graft tissue or cells in a variety of different ways. Maximal results, of course, are going to be used in conjunction with phototherapy. There is some long-term follow-up that suggests this could be beneficial, but as you might imagine, given this somewhat of a physical modality, there can be limitations on where you might potentially be able to get this type of treatment. So in the case of our particular patient, she's tried topical corticosteroids without relief. She's had extensive periorbital and eyelid involvement, making those not great options for her. She's used topical calcineurin inhibitors, the tacrolimus that was mentioned by Dr. Rosmarin. Really no appreciable improvement after 3 months of twice daily use. So this brings us to our next question. Get those fingers ready, folks. Which treatment would you recommend next for this patient? Autologous grafting, oral mini pulse therapy, ruxolitinib cream, antioxidant supplements, and of course our favorite, I don't know, ask Dr. Rosmarin, he probably knows what to do. So I will give everybody a little time to respond. I personally think that there is some merit theoretically to any of these therapies. The oral mini pulse therapy, probably not what you're going for since this isn't a patient really rapidly progressing and having super active disease. Antioxidant supplements, they can be nice adjunctive approaches. Autologous grafting, typically after you've exhausted medical therapies. I like the idea of ruxolitinib cream. You like that idea, David?
I think that's a very appropriate treatment for.
So based on the answers we're seeing, it looks like C is pushing through near the top, and we have sort of a few others, and that would be the right answer as far as Dr. Rosmarin and I are concerned. So let's talk a little bit about the last part of this case, and then we're going to get into JAK inhibition and signaling with Dr. Rosmarin. So for this patient, ruxolitinib 1.5% cream, a topical JAK inhibitor that is indeed indicated for non-segmental vitiligo. Remember those words and document them well. Was prescribed to be applied twice daily to the affected areas. Take it away, David.
So in order to understand why JAK inhibition and ruxolitinib cream makes sense, we have to go back to the pathogenesis. And vitiligo is fundamentally an autoimmune disease. And key is that it's not a cosmetic condition, it's a medical condition, it's an autoimmune condition that's driven by Th1 cytokines, particularly interferon gamma. And how is interferon gamma signaling? Well, when it binds to the receptor on the T cell, it then signals intracellularly through JAK1 and JAK2, which activates the STAT and causes the transcriptional programming, which leads to killing off of the melanocytes. A key to this positive feedback loop and part of the problem with vitiligo is that the signaling is taking place through JAK1 and JAK2. So if you block JAK, you're blocking the interferon gamma signal, which is what will help patients get better when they have vitiligo. And you may say, well, don't our other topical treatments do that? Well, corticosteroids and calcineurin inhibitors, well, they can be good at certain disease axes, like for eczema and for psoriasis. They tend to not really work well when it comes to interferon gamma suppression. And that's why JAK inhibitors really play a particularly well-suited role for vitiligo, is because they have very good activity when it comes to suppressing the interferon gamma axis. So again, vitiligo, it's fundamentally autoimmune in nature. JAK is part of that signaling pathway through interferon gamma. And ruxolitinib cream is our first and currently only FDA-approved treatment for patients with non-segmental vitiligo. And it's approved for both pediatric and adult patients that are 12 years of age and up. It's used twice a day. And we have both short-term and long-term data showing its efficacy and safety, which we're going to review. And so before we do that, though, let's talk about the primary endpoint of the TRuE-V 1 and 2 studies, which led to its FDA approval. So when we evaluated ruxolitinib 1.5% cream for the management of vitiligo, it showed a 75% or more improvement in this facial VASI score at 52 weeks in what percent of patients? So did 20 to 30% of patients show 75% or more improvement in facial scoring? Was it B, 50%? C, 70 to 80%? D, less than 20%? Or E, I don't know. So here we are seeing some of the results come in, and most people are putting in 50%, which is the right answer. And we're going to go over that data right now. So this was the primary endpoint for the two phase 3 programs, TRuE-V 1 and TRuE-V 2, which were identical. The primary endpoint was at 24 weeks, and that at that time it was vehicle controlled, but then at 24 weeks, all patients received ruxolitinib cream, and we have more data for the 52-week mark. And we can see here that in both studies, about 30% of the patients achieved this F-VASI 75 at the 6-month mark, but it jumped up to about 50% of patients at the year mark. So you can tell about half of your patients are going to get 75% or more of their pigment back on the face at a year. And that's very consistent, not only amongst the phase 3 results that we see here, but also amongst the phase 2 results that we see. It's very robust, that number, that's about the percent of patients that improve. And the key with discussing with patients is not to rely on the 24-week mark, because unlike other conditions such as psoriasis and atopic dermatitis, where most of the improvement happens early, in vitiligo, the repigmentation process takes time. So you really want to make sure that patients are getting it not only a year, but even up to 2 years, really, for improvement, because our studies show that even more benefit is gathered by our patients beyond the year mark. Also, some of our studies show that in patients who are partial responders, well, they can still achieve an F-VASI 75 if they still are using the medicine beyond the year mark. So I think that's all really important information to give to patients and counsel them about their expectations. If they expect to get better in 3 months or 6 months, that's not the right expectations. They really need to go into the mindset that they're going to be using this for about 2 years. Some patients may even need more. But with continued use, we're seeing continued benefit. Now we're going to look at some pictures of patients who use ruxolitinib cream in the phase 3 program. So this individual had about half his face or more depigmented with vitiligo. We see at baseline. Already at 12 weeks, we see significant repigmentation, and by the 6-month mark, really is largely repigmented. This would be a very early responder that was from the study. The next patient we have is a teenager who had depigmentation around the eyes, nose, and mouth. And at the 12-week mark, you can see significant repigmentation around the eyes, but then not until the 24-week, and I think this is mislabeled. It's actually week 52. Oh, sorry, this is correctly labeled. In week 24, we see really nice repigmentation around the eyes, but the mouth is not fully repigmented yet. What I will comment on is knowing this patient is that at week 52, she then did get her pigmentation back fully around the mouth. What I also really like about this picture is you can also see one of the side effects of ruxolitinib cream. About 6% of patients will get application site acne. And here she has a little bit of acne at baseline. You can see that in her forehead. And perhaps it's a little bit worse at the 6-month mark in the cheeks. Now, all the patients, it's really mild or moderate. No patients had to drop out of the study due to this. And really, in my experience, patients don't discontinue the treatment. It's usually mild, and we can treat it with the normal ways that we use to treat acne. Here is a patient whose hand also showed improvement. As we now know, ruxolitinib cream is not just for the face, it can help improve the body. And even though the hands are a very recalcitrant anatomic site, patients can still get improvement there. Here we see an extremity that's also repigmenting in nicely in the follicular way. But the right advice for this patient at week 24 is to keep using the medicine. They haven't hit their maximal response yet. In terms of some key findings from ruxolitinib cream, it's that we're seeing even more patients improve with continued use of the medicine. So that even though it's 50% of patients achieving an F-VASI 75 at the year mark, we're seeing even higher numbers at the 2-year mark. And it's also the same is true for the body as well. Patients who are not super responders on the body, with continued use of the medicine, they'll see continued improvement. So on average, about half the patients at the year mark will have a 50% or more improvement on the body. So that brings us to the next question. What is the most common adverse event reported in TRuE-V1 and TRuE-V2, the phase 3 ruxolitinib cream vitiligo program, that were treated with ruxolitinib 1.5% cream? Was it A, thrombocytopenia, B, pyrexia, fevers, C, neutropenia, D, acne, or E, I don't know? So what was the most common side effect of using ruxolitinib cream? And already we see here that most patients most people on here are showing that it is acne, and that's in fact correct. Sorry, if we look at the data, about 6% of patients in the study had application site acne, almost always mild or moderate and not leading to discontinuation of treatment. Also, about 6% of patients can have application site reaction like pruritus. And again, these are also often mild. One of the reasons why we like to use ruxolitinib cream as a topical is because you help minimize the risks of a systemic agent. So we weren't seeing wholesale neutropenia, anemia, or other side effects, which may be uncommon, but you can still get with systemic JAK inhibitor use. And oftentimes I'm asked, do I monitor the blood with patients who are Rux cream? And the answer is no, because it was these side effects were monitored in the phase 3 study, and we weren't seeing signals for lab abnormalities. I don't check it in clinical practice either.
So let's touch on some of the emerging strategies before kind of David and I put it all together and chit chat a little bit and answer some of your questions. And I don't want to spend too long on this, other than to say, if we had sort of talked about the vitiligo treatments a few years ago, there would have been much to talk about, number one. And number two, there probably wouldn't have been this kind of flurry of activity that you see in front of you. But now there's a lot of really cool, interesting emerging data for several JAK inhibitors across a variety of different phase 1, 2, and 3 programs. And I know that I'm particularly excited for the prospect of not only sort of topical agents, but oral agents too. So some of the most recently presented data that probably is very exciting on here is ritlecitinib, a JAK3 and TEC inhibitor. There was recent presentation of upadacitinib data for phase 2 just last week, actually, in terms of vitiligo improvement. And vorasitinib is another oral JAK inhibitor as well that's had some others. But you can see here there's additional treatments that are being looked at in the case of vitiligo. So really exciting things to come for our patients. I want to touch on kind of the ending of our case for a little bit of closure. And our patient returned 6.5 months later. She was excited and optimistic by the amount of repigmentation, especially around her eyes, no side effects. The physical exam was consistent with everything you heard Dr. Rosmarin talk about. And there was some patchy areas of depigmentation. And she's not yet started using it on other affected body parts, but really is motivated to do so. And she states that she's relieved and excited to continue the medication to try and achieve full repigmentation in the areas that caused her distress. So I think the big conclusion here is that you want to make sure that you are sticking with your patients, getting them to come back in reasonable time frames, setting the right expectations based on the data, and really sort of being a cheerleader in some ways, because this is going to take its time to work. And in this particular case, you can see here 6.5 months, reasonable time frame is when this patient is really starting to feel optimistic about the changes that she is seeing. And you can already see that quality of life and probably even mental health is so connected to that improvement that this patient is getting. So with that being said, let's kind of wrap things up with some closing thoughts here first. So a couple things that I want to touch on, David, and then sort of I'll let you sort of add yours as well, is that really vitiligo is about the whole person. It's not just what you see on the skin. It's not just the pigmented patches, but in this particular case, quality of life, mental, physical, psychosocial burden, and mental health symptoms in particular are key. And you have to understand that, like a lot of other inflammatory diseases, you really need to look beyond just what you see on the skin. That psychological burden, for instance, is just the one that's so well documented. And there is a fascinating history of vitiligo and the way that it's created unique burden in various cultures and civilizations throughout history.
So I can't echo that enough. That what Dr. Chovatiya said is that this can have really a big effect on patients, and it's really important not to make assumptions either. So you may think that a patient who is very fair-skinned is not affected by the vitiligo, but they really might be. Similarly, some patients who may have very noticeable vitiligo but aren't bothered by their disease. So you never make assumptions and always need to have that shared decision-making process with patients. In terms of the pathogenesis, we really have now well established it's fundamentally a Th1 disease driven by interferon gamma through the JAK-STAT signaling pathway. Therefore, it makes a lot of sense to think about a JAK inhibitor as a treatment, and it's been proven to work not only in multiple studies with the topical, but there are now systemic oral JAK inhibitors that are also proven to help repigment patients with vitiligo. So key points here are that you can make a big difference in these patients' lives, not to make assumptions, and really help them out in a compassionate way that dermatologists know how. So now we're going to address some of the questions, and we have a bunch in the chat. Let me first ask Raj the first one. Do you see vitiligo in patients who also have atopic dermatitis?
Yeah, that's an interesting question, right? Because we think about these as sort of type 2 inflammation versus type 1 inflammation. don't get it twisted. You can see anything in anybody. And so I have patients actually that have had atopic dermatitis and vitiligo both. It's not the top of the list in terms of comorbidities, particularly inflammatory disease we're thinking of. But if you look at your patients, atopic dermatitis is just so prevalent epidemiologically that you are going to have patients with vitiligo that also have atopic dermatitis. Remember, there might be different things throughout the history of the patient's life as well. So while vitiligo may be the reason they come to see you, they may have had eczema in the past or even sort of mild eczema chronically anyway, and it may have very little to do with the vitiligo itself.
Yeah, and really interestingly, what we just published is that patients who have some Th2 cytokines that also have vitiligo may actually be better responders to ruxolitinib cream. And there was just last week at the EADV information that if patients have atopic dermatitis and alopecia areata, they're also more responsive to JAK inhibitors. And we also view AA and vitiligo very similarly, that there's this big, strong Th1 component. So I think it's really interesting that patients who may have some Th2 disease may actually be better responders, and not necessarily opposed. You can have both Th1 and Th2 active.
Maybe we'll do a little rapid fire, David, and I'll ask you a couple in our last couple minutes. Give me your quick takeaway. What's the dosing for systemic corticosteroids when it comes to somebody with actively progressive disease? What do you use?
So I usually use dexamethasone, 2.5 milligrams daily for 2 consecutive days of the week for 12 weeks. So for example, dexamethasone, 2.5 milligrams on a Saturday and Sunday for 12 weeks. And that stabilizes the disease in about 90% of patients.
Exactly what I do. Love it. Quick question about the trials. Were ruxolitinib studied in monotherapy or in conjunction with topical therapies or UVB? What was happening in the true V1 and V2 study?
These were monotherapy studies. This was looking at ruxolitinib cream alone without any other concomitant topical or without any phototherapy. So that's what makes these results very impressive. If you add in phototherapy, which is now being studied, we are optimistic, well, maybe we can even get better results.
I can feel this one. How would you counsel a patient who develops acne while it's being treated with ruxolitinib cream? And I think it's important just to review the potential risk of adverse events with the therapy, but the nice reassuring feature from the trials was that this was typically not treatment limiting or treatment discontinuing for patients. You know, for those that I've seen in the real world that have had acne or folliculitis with JAK inhibitors in general, sometimes it goes away without treatment. Other times, the most you usually have to do is a topical antimicrobial or topical antibiotic, standard stuff that we do as dermatologists, and that's pretty sufficient for my patients. I want to ask you one question, perhaps the last one here, Dr. Rosmarin. Do you counsel your patients to avoid laser hair removal if they have vitiligo, or do you worry about it potentially causing capillarization and more vitiligo?
That's a great question and a very practical one. So I can't promise the patients that they will not capillarize and it will induce vitiligo, although the chances are low. And so for patients who are interested in laser hair removal, I'll often recommend that they do a test spot, but I'm very honest with them and say, look, this is a real risk. I'd recommend you do a test spot first to see if you capillarize or not. I'll also discuss there are other options as well, such as electrolysis, which can be used as alternatives to the laser hair removal.
Yeah, really good point. And I think that that's similar to the counseling that I have. I think we always worry about any type of physical stimulus or physical modality in our patients with vitiligo, not knowing if we're going to be making things better or worse for that patient. Hopefully you enjoyed what we brought you guys tonight. It was a real pleasure, David, to participate with you and sort of taking a really rapid fire look from top to bottom at vitiligo and really thinking about where we've come and where we're going.
Thank you, Raj. Always a pleasure.
And thank you to everyone for tuning in.